experimental study. They were actually able to show, and I don't know how they got the volunteers for this particular study, but normal volunteers could be infected with less than 2 bacilli per ml. So it can be viewed, depending on the right circumstances, the right set of circumstances, quite frankly, it can be highly contagious. The droplet nuclei are inhaled. They are then travel down to the alveoli where they're ingested, phagocytized by the alveolar macrophages. And the key thing about MTB is that there's been concomitant evolution, as I referred to before, between our cells and between the organism. Following engulfment, the organism, many intracellular organisms are exposed to our innate immune responses and are killed intracellularly. What happens with Mycobacterium is they actually have evolved a series of proteins that prevent or protect intracellular existence. Now, their rate of replication drops off. They're quiescent, but they can still undergo slow replication within the cell. There are actual proteins that MTB has evolved in its genome, which are secreted in the context of intracellular survival, which actually prevents the fusion of lysosomes that contain killing or enzymes that can kill the organisms. And it will selectively block the fusion of the phagosome with those lysosomes. So consequently, it will protect the organism. And the other thing that's interesting is that there is a fish model, there is a zebrafish embryo model, which has been developed now over the last 5, 6, 7 years, which was published in Cell in 2009. And they actually used zebrafish embryos. And what they were able to show is that following phagocytosis of the organism by the macrophage, the organism can remain dormant or quiescent within the cell, undergoing slow replication. And we all think, and what you've been taught, and this is true, is that you form a granuloma. Those macrophages form a granuloma, and it's a wall against the organism to contain it. That's true, but it's a two-edged sword. Because apparently, based upon this model, and admittedly it's somewhat different from the human model, it's a zebrafish embryo, and the organism they're used is Mycobacterium smegmatis, not TB. But apparently that's the particulars they were able to develop the model with. And what they showed is that when those macrophages die, and they do turn over slowly, the organisms are still viable. The cells are, rather the bacilli, which are still viable, are ingested by a new macrophages, and some of those new macrophages break off of the initial granuloma and will travel to other parts of the body and form their own granuloma. So the point is that the granuloma is a two-edged sword. Not only does it provide protection against the organism, but it also facilitates the spread of the organism within the body. Okay, anyhow, the bacilli spread throughout the lymph nodes and the lymphoid system, and then they enter the blood, and they can seed in multiple parts of the body. You know, this happens with everybody following primary infection. If you're old enough, your immune system will contain it in those various portions of the body. But the question is, it's very likely that you will be infected, even if it's latently, for the rest of your life. The question is, and I don't think there's a good answer to this, is can we totally eradicate that latent infection? And I'm not sure we really have data to say that we can. All right. Now, antibodies can form against Mycobacterium tuberculosis, but we really don't know what they do. They're not useful diagnostically. They are not useful from the standpoint, as far as we know, in terms of containing infection. They just remark, and the thing is, over the course of time, we've begun to realize, too, that there are differences between strains of MTB. So they cannot, right now, they are not a useful clinical tool. All right, what about people who are at risk for developing TB disease? This is following latent infection. Those who have been recently infected, and certainly if you're a young infant or a young child, there's a higher degree of developing TB disease. Those with clinical conditions that increase the risk of progressing from latent to TB disease. And these include close contacts with persons with infectious TB, recent skin test converters within the last 2 years, recent immigrants from TB endemic regions of the world, sub-Saharan Africa, children under 5 years of age with a positive skin test, and resident employees of a high-risk conjugate settings. There was an AIDS epidemic, there was an AIDS clinic in Boston associated with Harvard Medical School that was established to handle the influx or the relatively large number of HIV-infected patients that were presenting. And someone got the bright idea that it might be a good idea to actually start screening not only the patients, but also the staff for TB. And during one of the papers that came out of that clinic showed that practically 100% of the individuals working in that clinic had skin test converted, had actually developed latent infection as a result of exposure to the HIV-infected population they were serving. This was a period of years ago. Okay, persons who are more likely to progress from latent to TB disease, HIV-infected individuals, those with a history of prior untreated TB or fibrotic lesions. Now, latent disease by definition, clinically is defined as not being clinically ill, having a normal chest x-ray except for one exception, and I'll talk about that in a minute, and also having a positive PPD. And obviously, if you have a history of known exposure to a TB contagious person, that fits into the formula too. That's the first or the most common form of the disease, and it's a lot easier to treat because all you need to do is treat for 9 months with INH, with or without B6, depending upon the age of the individual, their nutritional category, so forth and so on. The only exception on the category that it would still fit with latent disease if you see calcified nodules on the chest x-ray, which is consistent with old primary TB that did not develop to clinically evident disease. That is not active disease, that is still consistent with latent disease and can be treated with just one drug, the INH, okay, or isoniazid. Those who are malnourished, injection drug users, those receiving tumor necrosis factor antagonists. There's been a slew of advertisements in the US, and I suspect here too, for various well-known celebrities who may have a form of arthritis or Crohn's disease, who have been treated with a number of commercially available now monoclonal antibodies against tumor necrosis factor alpha, one of whom is Phil Mickelson, who is a very successful professional golfer. The problem with this is the disclaimer at the end of those commercials is, if you have TB, or if you're from an area with certain fungal infections, and they're talking about histoplasmosis in those individuals in the Mississippi River Valley, or coccidiomycosis in the southwestern US, or certain endemic latent fungal infections, and you're treated with these entities, if you knock out the tumor necrosis factor alpha, the chance of reactivation of the fungal element or the fungal disease or of TB goes up astronomically. So that's where that fits together with this, okay? Now, persons with certain medical conditions, silicosis, diabetes mellitus, chronic renal failure, solid organ transplantation, carcinoma of the head and neck, or gastrectomy, or jejunal ileal bypass. Now, the clinical features. Let's go into what I mentioned before. Are we okay on time?
Yeah.
Okay. Shut me up if I go over. Okay. Anyhow, there's two things about kids with TB. There is primary disease resulting from primary infection and reactivated disease. If you look at things across the board, the most common clinical picture that the child with symptomatic clinical disease secondary to tuberculosis is pulmonary disease. That makes perfect sense. If you look at the total mass of children who have been infected with TB, the most common presentation, as it is with adults, is latent. Now, obviously, I'm talking about older kids. But even in the kids under 1 year of age, you still have a 50% chance of just developing latent disease without primary. The difficulty in diagnosing childhood TB is with the primary disease resulting from primary infection, because it's a different type of disease than older infection. There's usually nonspecific signs and symptoms: cough, fever, weight loss, failure to thrive, malaise, loss of energy, occasionally vomiting and diarrhea, and rarely night sweats. You're always taught that night sweats, you should ask about night sweats, and you should. I'm not saying stop it. But in terms of the frequency of finding a child, especially a young child with what is primary disease, saying he has night sweats, it's not common. It's more common in older children and adults who have reactivated disease. Now, if you think about the pathophysiology of primary infection versus older disease, and this is a key point, primary infection has been described as paucibacillar. So there's a lower number of organisms. I also happen to believe that it is also primarily an intracellular population as opposed to reactivated disease where you have cavity formation, you have a large exponential population of rapidly multiplying bacilli. I think there's a point in primary disease where you cross that threshold from primarily intracellular with slowly replicating organisms to a more clinically obvious with rapidly progressive bacilli and obvious elements of disease. That can seem it. But the reason why early primary disease in children, young children, is so difficult to diagnose is because it's hard to document the organism. In the majority of series from both the US and from Africa and other parts of the world where TB is common, the frequency of getting a positive culture out of a child, a young child, even with gastric aspirates or induced sputums, is only on the nature of around 30 to 40%. Okay, and it fits perfectly with the understanding that I'm trying to project to you. It's a somewhat different disease with a different pathophysiology, okay? Now, children, if they have more progressive primary disease resulting from initial infection or in fact reactivated disease, can have bronchial breathing, crackles, diminished breath sounds, and stridor, but it's usually when they've gone to the point of the organism replicating and affecting the surrounding bronchioles. And if it ruptures through the wall of bronchioles, that's when you start getting blood. That's when you start getting all that beautiful stuff coming up on induced sputums, okay? And there's a higher possibility of seeing a positive culture in that latter case. Now, the key thing, that there is an excellent book on childhood TB. It was written by Peter Donnell. Peter Donnell is a British-trained physician. He's Professor Emeritus of Pediatric Infectious Disease at the University of Cape Town, in Cape Town, South Africa. He is one of the most knowledgeable people on clinical presentation of child. He's dealt with it all his life. The book is about $50. It's available online. I think it's just called Childhood TB. And it's in paperback. It's excellent. But the beauty of it is that he basically has put his life's existence into the book. And in the chapter on chest X-ray diagnosis of childhood TB, it's very apparent that the most common finding on a chest X-ray with the child with evidence of primary disease is either peritracheal or perihilar lymphadenopathy, what's referred to here on this slide as mediastinal lymphadenopathy. Now, if you remember your basic anatomy, do you remember where the lymphatic drainage drains to? From the left lung? It goes from the left to the right. And this is sort of an example of what happens with kids with perihilar lymphadenopathy. Many times, if it's more progressive, you'll see bilateral perihilar lymphadenopathy. But preferentially, in the majority of kids, you'll see right-sided, even if the left lung is involved. Now, the so-called GON complex, the GHON, that everybody teaches you, and it's a good thing to know. I'm not, because it might be on the boards, okay? That's the reason I'm mentioning it. So you got to play that game. Anyhow, there's three elements to the GON complex. There is the perihilar or peritracheal lymphadenopathy. There is the peripheral pulmonic infiltrate. Those two things are the most common. Usually you'll see, most commonly, the mediastinal lymphadenopathy, the peritracheal, the perihilar lymphadenopathy. Less commonly, but still you can see with primary disease, peripheral pulmonic infiltrate with the perihilar lymphadenopathy. The third element is the linkage. It's the lymphangitis that connect the initial focus with the perihilar. Now, you rarely see that. So the bottom line is the classical GON complex is not common, but the elements of it are. You need to take a look at those. The atelectasis, the consolidation, the air trapeze, the pleural effusion are all part of progressive, either primary or reactivated disease once it spreads beyond the initial nidus of infection and it starts affecting the surrounding structures. The miliary pattern, which has also been described radiologically as reticular nodular infiltrates, is a diffuse pattern that can be seen with only a few other clinical entities. Number one, lymphoid interstitial pneumonitis, which is not common anymore. It was a manifestation of perinatally acquired HIV. It used to be fairly common, and when we first diagnosed kids in Miami in the early 90s, or even in the middle, early 80s, with HIV, maternal fetal HIV. And we saw this, a lot of the pediatric radiologists would essentially say in their reports that this is consistent with miliary TB. That's what it looks like. But lymphoid interstitial pneumonitis is something with HIV, okay? It's not common anymore because a lot of the kids with HIV are being picked up at a very early age and started on heart. The other thing that you may see with a miliary pattern is diffuse histoplasmosis or certain other fungal infections. Rarely you can see it also present as leukemic infiltrates as a result of reactivation or reoccurrence or relapse of leukemia. Cavitations, not so common in kids, very young kids, but more common in people who have reactivated disease. Okay. Now, the criteria for clinical taste definition of TB, this is as per the CDC, positive result on the tuberculous skin test, clinical and signs and symptoms consistent with MTB, abnormal or unstable findings in chest x-ray compatible with TB, but again, the most common thing you'll see is usually mediastinal lymphadenopathy. Now, the diagnostic microbiology. They are non-motile, aerobic, non-spore-forming bacilli who have a cell wall contact, high cell wall content of high molecular lipids such as lipoarabinopathy. I'm blocking on it now, but there's a variety of large molecular structures, complex glycolipids that make up the cell wall. The feeling is, or the speculation is, that a number of these things have evolved over the course of eons as a means of protecting the bacillus from our own innate immune system. It stains poorly with gram stain, but the cell wall binds carbonfusin dye and resists discoloration. This is hence the term acid-fast bacilli. The cell wall contains peptidoglycan and complex glycolipids, as I said, and it actually accounts for almost 10% of the cell wall content. Now, what we've learned over the course of the last 10 or 20 years is that there's been a great deal of research into the genome of MTB. And what has appeared is the same, it shouldn't be a surprise because the same is true of other bacteria, is that there are certain islets of pathogenicity. And one of these, which secretes some of the primary virulence factors associated with MTB, is called the region of difference, or the so-called RD1. Now, there are a variety of proteins that are elicited or produced by this particular genomic segment. But two of them, which are well known, are referred to as the early secretory antigen target 6, or ESAT6, culture filtrate protein 10. There's a third one, there's actually more than 3. There's a third one, which I think is TH7.7, which is also all 3 of these proteins from a recombinant DNA using recombinant DNA technology have now been incorporated into what's referred to as the IGRA, or interferon gamma release assay. We'll talk briefly about that. It's a means of diagnosing TB. Now, the key to the diagnostic microbiology is obtaining the appropriate specimens for bacteriological examination. You can use sputum, induced sputum, gastric aspirate. Gastric aspirate is what we traditionally use in very young children. And what you have to do is, if the child is at a very young age, if they can't be cooperative with getting induced sputum, you admit them to the hospital, keep them in the hospital for 3 days, and every morning for 3 days, you go into them theoretically, before they get up and start running around the crib or the bed or the room or whatever, and essentially insert a nasogastric tube. You then instill and you wash the stomach. The point is that while the child has been recumbent all night, all the gastric content, all the material that he may have coughed up and swallowed has accumulated in the stomach, hopefully including viable MTB if that's what he has. You can also culture a number of other things: BAL fluid, lung tissue, lymph node tissue, bone marrow, blood, liver, CSF, urine, and stool. And actually, people are looking at stool in a number of studies in sub-Saharan Africa right now as a means of screening for MTB. Okay, if you find MTB, if you're able to prove it on a culture basis, that is consistent with what's called a proven case. Smear is another way of diagnosing, but the problem with smearing is that a number of us have commensal atypical mycobacterium in our tracheobarbial tree, including such agents as MAI, Fortuitum, Kansassia, and these are not necessarily pathogens. If you are immunocompetent, it's not a problem. If you are immunosuppressed, I mean, I can recall a case of a child with advanced stage HIV years ago who had MAI that we retrieved upon a bronch when he didn't have any clinical, he had some clinical disease, that's why we did the bronch. But over the course of time, what became apparent to us is as his degree of immune suppression worsened, the degree of replication of the organism giving rise to significant lung disease and eventually bacteremia secondary to MAI worsened. Okay. The other stains that you can use, Zeal-Nielsen, Kenyon, the fluorochrome strains, the Auramine. This has been very useful. As a case in point, there was another child with advanced stage HIV who came over to us from Miami Children's, had fulminant watery diarrhea. When we worked the child up and we sent a segment of the fluid that was his stool down to Mycobacterium, to the mycobacteriology laboratory, they called us and we came down and looked at it under the fluorescent microscope, and he had sheets of organism in that stool, and what they were MAI. And the stool itself, under the fluorescent microscope, looked like Van Gogh's Starry, Starry Night. It was that populated with organism. Okay. Gastric aspirates, the most commonly processed sample for children. However, remember what I said before, only about a third of these cases, even if you do it under the best circumstances, are culture positive. And that's in the case of young childhood TB, which again, let me emphasize, it's a somewhat different disease from TB in older children. Culturing specimens, gold standard for diagnosis. The problem with this is that for years we've been hampered by the time. It's a slowly replicating organisms, so it may require 3 to 6 weeks. There are a number of automated techniques which have now been cultured, which are now been developed to sort of facilitate that. I'll skip over some of this. Now, this is something that has been just literally within the last, I think, 6 to 10 months, approved by the US FDA for use in the US. So we're behind the ball. Because the reality is the expert assay, which is a PCR-based technique, is something that's been used in Africa for at least 10 to 15 years for diagnosing TB. And it is a PCR technique. I will not go through the details of it, but essentially the beauty of it is the primers that they use in the expert. And that's the official commercial name. Actually, with the tech, not only the genomic parameters that identify the species as MTB, but it also identifies the particular portion of the genome that contains the bulk of the resistance mutations against rifampin. So in one test, it's theoretically possible that you can identify both the organism as being MTB and also determine whether it's sensitive to rifampin or not. It does not have the technology for determining an INH resistance because it turns out that there's over apparently 100 mutations that have been associated with INH resistance, and they are not focally located within a particular portion of the genome. So they have not been able to incorporate it into this assay. All right, this is the data. This was published in Lancet Infectious Diseases, I think about 2 years ago, actually within the last year, quite frankly. A number of studies involving children using the expert, and the gist of what this says, and I'm going to, Eddie, they will have available, they'll have this slide talk available to them if they want to spend time on it, okay? There's a number of, these are prospective studies that were done in a number of countries, usually in sub-Saharan Africa, Tanzania, South Africa, Italy, which is not Africa, obviously, Zambia, where we've been working. But the key thing here is the expert really represents a step ahead in terms of facilitating the diagnosis of childhood TB. There are still problems with it. And the main thing you can say about it at this point is the company that manufactures this thing, working with the World Health Organization, has actually been able to negotiate a reduced price for the machinery and for the logistical support materials so that they can make this available to even secondary or tertiary care laboratories in these countries. So they are currently using this assay in many of sub-Saharan African countries. to actually test specimens that are brought in from the bush. So, and the beauty of it is because it's a PCR, theoretically, it can be done within 24 hours. So you don't have to wait for 3 to 6 weeks until you grow the organism. Now, its utility is still in question. I think there's more data which needs to come out. It's very apparent that this will probably replace smear. And again, the problem with smear, and I was the chair of a protocol, TB protocol in South Africa that started in 2004. It's still ongoing. The protocol is closed, but our analysis is still ongoing. But what expert has really proven a tremendous boon to is that as opposed to getting a false positive because of commensal atypical TB on a smear from the tracheobronchial shriek, this particular assay will give you a definitive answer as to whether that AFB is MTB versus another species. Okay, the IGRA. The IGRA is an immunological test. It is based upon the same principle as the PPD, which is the skin test. And essentially what you're doing here is you're drawing blood and mixing the blood with antigens from MTB. There is also, some of the antigens have a degree of cross-reactivity with some of the subspecies within Mycobacterium avium. And then incubating the controls and the specimens and the patient specimens for a varying length of time. It can be done in a couple of hours. Theoretically, again, the turnaround time is the real advantage here. If you are working with a facility, and my facility is good, but my facility still can't do this in 24 hours, but if you're geared up and you're getting enough specimens, theoretically you can get your answer within 24 hours. The principle, as with the PPD, is the lymphocytes that are primed to MTB will recognize the antigen and release gamma interferon, and the positive results is correlated with the level of gamma interferon, which is measured in the supernate. Okay, now the three antigens that were used in this, again, ESAT6, the culture filtrate 10, two of the ones from the region of difference. The third one is also there. There are certain modifications of the assay which are essentially the same principle. And the CDC's recommendation, and this was as of December of 2010, that the skin tests and the IGRAs, the one that's in use right now is called the IGRA, it's called the quantiferon into gold. That's the one that's commercially available. Can be used as aids in TB surveillance. It generally should not be used for testing patients at low risk. The selection most suitable test based upon the context for testing. It may be used in place of and not in addition to PPD in all situations in which the CDC recommends. The key thing about diagnosing TB, especially in young children, is you need to look at the gestalt picture. Occasionally, you get reactivity on the quantiferon and it's a false positive, but it's not high. The specificity of this test is much better than the PPD. The beauty of it is you're not going to see any reactivity from prior BCG vaccination in a patient. Okay. The IGRA is preferable for patients with low return rates, but here again, that's assuming that your facility can get the results back to you after the first day. Okay. Okay. Now, the PPD. This is what you're all familiar with. The PPD has been used for over 50 years for diagnosing TB. And remember what I said toward the start of the talk, that quite frankly, the PPD is derived from Mycobacterium bovis. The strain that they used when it was first derived probably had genomically was closer to MTB than the one that's currently in use. It produces a delayed type hypersensitivity reaction to certain antigenic components of MTB. Typically the reaction begins within 5 to 6 hours. However, you never read it until 48 to 72 hours after you place the scan. Now, by convention, we usually put the PPD on the left arm. We no longer use controls. For years, we're using Canada controls, and they just finally decided it was a waste of time. All right, the methodology, straightforward. You inject 0.1 ml containing 5 tuberculin units intradermally, not subcutaneously. You want to inject it, so what you do is you approach the left arm from an angle like this, inject it intradermally so it creates a wheal. The wheal will typically disappear within a matter of hours as the fluid is absorbed. It's not totally absorbed because the antigens are still there. If you see a reaction within 24 hours, usually that doesn't mean that it's positive. If it's primarily erythema, that's some type of hypersensitivity to usually the reagents or the vehicle or something like that. You wait for 48 to 72 hours, and what you're looking for is a positive reaction. You measure the induration and not the erythema. And as you can see what they're doing, and it will appear as a bump that will be firm. It's usually not painful. However, one of the things I will tell you, if a person is PPD positive, the recommendation is they should never get a PPD again. Now, if you do it years later, you're probably not going to have a problem. If you find a positive PPD on a kid, say who is like 7 years of age, and he goes back and you find PPD and you treat him for 9 months, and next year he's screening, his mother says, well, I've been called by the school and the school wants to repeat the PPD. Don't let them, because it's an immunological reaction. If you do a closely spaced and temporally spaced repeat PPD, you may form an ulcer or a crater. So you can augment the immunological response. However, if a person has not been primed to PPD, there is no danger that if you repeat the PPD, you'll get a false reaction. Okay? So record the reaction in millimeters. The definition of what is positive, if the induration is more than 5 millimeters, that is considered to be positive in an HIV-infected person. A person who's had recent contact with an active TB cases, evidence of fibrotic changes, that is the calcified nodule I referred to before on the chest x-ray, a person who has undergone organ transplant or is immunosuppressed for another region. If in fact their degree of induration is greater than 10 milliliters, and they are recent arrival or an ID drug abuser, or if they are resident employees of a jail or some type of similar setting, work in a mycobacterial lab, clinical conditions that make them high risk, or children less than 4 years of age, that is consistent with a positive reaction. If the PPD is positive, if it's positive and it measures greater than 15 millimeter, you don't have to have any risk factors. That's a positive PPD. Okay, now I'm going to end by basically giving you the baseline in terms of therapy, because we could spend hours talking about therapy, especially in this day and age of multi-drug or extreme drug-resistant TB. That's the subject of a more advanced talk. Okay. The beauty of TB these days is you can treat it. A century ago, 150 years ago, the list of well-known people in the U.S. who died of TB was legion. Lincoln's second son, actually his first son, it was his second son, it was Eddie, died in 1852 of tuberculosis. Edgar Allan Poe died of tuberculosis. A number of very, very well-known people succumbed to tuberculosis. It was that common. And it's probably because part of it may have to do with sanitation, but part of it's because if the larger portion of the population is latently infected with TB, and they're immunosuppressed or the stress, or you have a comorbidity that puts you at higher risk for developing active TB, it just adds to the population. Now, the first-line drugs, which have been developed, they've been in place now, available for over 50 years, isoniazid and rifampin, paracetamide and ethambutol, these are the primary agents. They are all bactericidal. These are the doses. The side effects are listed there. Peripheral neuropathy, hepatitis, elevated liver functions. Now, the key thing about isoniazid, liver toxicity defined by an elevation in liver functions. Before you start a child on isoniazid, you always check the liver functions. And you don't start unless you have normal ones. The frequency of peripheral neuropathy is not common. But for certain individuals who are malnourished or during the adolescent years, they will need B6. And the reason you give the B6 is to offset or decrease the possibility of peripheral neuropathy. If you do have a child who has elevation of liver functions or comes in and is jaundice, has scleral icterus, what you can do is stop the INH for 1 or 2 weeks, have them come back. If it resolves, you can re-challenge them with the same dose of the isoniazid, and in many cases, they'll do fine. I've done it myself. The rifampin, the same dose. The maximum dose of isoniazid for an adult or older child is 300 milligrams. The maximum dose of rifampin is 600. The key thing about rifampin, you need to educate the patient. You need to educate the family. It will turn their tears orange. It will turn their pee orange. If they're wearing contacts, it will discolor the contacts. So you need to tell them about that. Okay. The parazinamide. The key thing about what's called short-term chemotherapy for the treatment of primary or reactivated disease with TB is usually, depending upon the frequency of drug resistance in your geographical area, is usually 3 for 2 and 2 for 4. And by that I mean it's a 6-month course. For the first 3 months, if it's 3 for 2, isoniazid, rifampin, and parazinamide during the first 2 months, and then isoniazid, rifampin for the last 4 months. If you're in an endemic region for single drug TB, then you go 4 for 2 or 2 for 4. And the 4 would be isoniazid, rifampin, parazinamide, and ethambutol. And then the last 4 months, are isoniazid and rifampin. The parazinamide is relatively non-toxic. You can usually use a dose of 20 to 25 milligrams without any problems. The ethambutol, be aware of this. If you're going to use it in pediatrics, there are 2 doses that are recommended, 15 milligrams per kilograms per day versus 25. The 15 milligram is said to be bacteriostatic. The 25 milligram is said to be bactericidal. The reason why we use the lower dose is because there's a serious toxicity that you can see with ethambutol. And it is retrobulbar neuritis, and it may be irreversible, and it may result in certain vision loss. So before you start a patient on any ethambutol, you always check their color vision, because it's a harbinger of potential toxicity. In other words, if you do the color vision test and they have normal color vision and they come in, say, 2 months later while on the ethambutol and they said, well, I'm having trouble seeing certain colors, you stop the ethambutol, because it's sort of an early warning system. It's a screening test for the possibility of retrobulbar neuritis. Luckily, it's not common in kids. It's more common in adults, especially if you use the lower dose. And with that, I think I'm going to stop. The vitamin D is, there's a number of slides that I have not touched on because we really haven't had the time. I'm going to leave the slide set for you so you can go through it at your leisure. Any questions?
Very. We can have your own time for discussion, comments, questions to Dr. Mitchell about TB and HIV.
Yep.
Well, first, after the basic presentation Dr. Mitchell gave us, I wanted to ask a question to you, Dr. Perez. If you know in the country they're doing some research about tuberculosis, or if the country has any specific procedure right now about tuberculosis.
Research about tuberculosis in terms of what? In general?
Yes, in general, as he said during the presentation, that it was a really hard topic to get funding and to actually present any type of research. I would like to know if you know if there is any type of research about tuberculosis here in the country.
Well, yes, you will be surprised, the amount of research study, that we have been conducted since, the early 90s. In tuberculosis, you can find, for example, one of them in Lancet that was, we were trying to, by that time, let's say 1992, 1993, you probably was about 1 or 2 years old, by that age, right? So,
both of us, you realize.
yeah. So, we were trying to see if by that time, if the HIV, in persons with HIV infection, the tuberculosis was transmitted in a more effective way than those are HIV negative, okay? And that study was conducted here in America. We were the ones who conducted that. We have plenty of observational studies, research studies about multi-drug resistant. We have 2 national surveys about multi-drug resistant TB. We have also one in TB treatment outcomes. So there are plenty of them. Okay. Uh, um, what I have now, or what I heard from the national TB program is that they are trying to update a research study that I conducted myself, in 2006, was about TB and HIV, was a co-infection. So they are trying to update that study with PAHO, the Pan American Health Organization. And the person who is conducting the study is Dr. Ricardo Diaz, a pediatrician and also a former tuberculosis director, former director of the tuberculosis program in Galicia Coast. Okay, so no, we have plenty of studies. We are conducting. We conducted one. Was not formally a TB and HIV, but was one with the University of Miami. Okay, was a review, was a systematic review with Gwen Scott. Okay, so plenty of them. All right. So I don't know if I answered your question.
Yeah, there's one of the things that we've discussed about while I've been here this week is that as a result of this TB protocol that I was one of the originators of, that has been done in South Africa, and the purpose of the protocol was to look at the efficacy of primary INH prophylaxis among HIV-infected and HIV-exposed South African infants. And the purpose was, considering the frequency of TB disease in young infants in South Africa, both HIV-infected and uninfected, whether if you started them on INH and gave it to them for 2 years, and it was a double-blind placebo-controlled trial, and gave it to them for 2 years, could you decrease the incidence of TB disease, both driven by culture, problem based upon smear, and also look at whether we could decrease HIV-associated morbidity and mortality. And it didn't work. We found out, and I could go off another hour about that, and I'll shut up about that. But the reason I'm bringing it up is that, and I've spoken to Eddie about this, one of the people that I'm working on that protocol, who we've started a conversation over the last year, is Dr. Ed Gravas. And Ed is at Methodist Hospital in Houston. And, I'm sorry, Ed is at Methodist Hospital in Houston. And he and a colleague of him have developed, one of the key things in the problems with diagnosing, as I said before, primary TB disease in young children is actually achieving the diagnosis. There's a number of clinical scoring systems which have been developed which are not good. They're good, but they're limited in terms of their sensitivity, the specificity, the positive predictive value, and the negative predictive. What Ed has developed with a colleague of his is nanotechnology to be able to pick up the particular proteins, ESAT6 and culture filtrate 10, in the plasma and serum of the patients. And so he now has about 20 specimens from cases that were part of our protocol 1041. And the results of that study were published in New England Journal in July of 2011. But he has 18 or 20 specimens from those kids, and he's running them right now. And I've already emailed Ed telling him that I may be able to work something out so we can get specimens from here and also from Zambia, where I also work. And childhood TB in Zambia is very common.
Okay. I'm happy to hear, that Dr. Mitchell mentioned, about PPV, MPV, sensitivity and specificity. Now you see, that it's not only in the books, it's also that you need to apply.
See, that's the nice thing about academic medicine, is because we are consistently reminded how much we don't know.
Andrew.
I actually had 2 questions, if that's all right. You talked about the funding being a little scarce at this moment because the U.S. government, being that they are having to cut some of the budgetary funds. Are there any private foundations, private organizations that are bringing the charge?
Yes. I think one of the people in the U.S. I have tremendous respect of is Bill Gates. And I think he's set an example, and there's a number of other. Warren Buffett has contributed, God knows, billions. I think there was something a year ago or so, he devoted 50% of his fortune or something like that. Phenomenal number. Hey, I'm down here, I could use some of that too. But the bottom line is Bill Gates is obviously a brilliant man. Some say he's a genius, and I'm not going to question that. But he's done something. You know, he's decided with his wife, his first wife, that he's going to try to do some good. He's sort of the Andrew Carnegie of this century. And he is going to leave an indelible mark. You know, what he did about malaria in Africa is rather than, it's not that he didn't support research, but more importantly, he put the millions of dollars of money out there from both himself and from people he knew or the people that had donated to the Bill and Melinda Gates Foundation to buy staples, pesticide-impregnated bed nets, and other simple things that decrease the transmission of malaria. And malaria, for years, as I'm sure you well know, is a major killer of children in many parts of Africa, and the numbers are going down. So it doesn't always take the high-powered technology. It's simple things, but it's the effort and somebody making a difference, and he has made a difference.
Just to recall about that, remember the human security, okay? The human security class we have, okay? So you see, you know, you can save lives just with bed nets, right? Thank you.
And the second part was a little separate from this topic, but you talked about the ethambutol that's threatening to stop if you see a loss of blood vision. Are those reactions reversible afterwards?
Well, you know, here again, luckily, I've never seen it. One of the people I have a great deal of respect to in the academic community is Jeff Stark. And Jeff is a colleague of mine. He's a friend of mine, too. He's a hell of a nice guy. Very, very well known. I think Eddie may know him. But he's on faculty. He's a professor of pediatric infectious disease at Baylor in Houston. And Jeff has devoted his whole professional life to the study and research related to childhood TB. And he's one of the if you go to some of the salient textbooks or the most well-known textbooks in pediatric infectious, Feigen and Cherry, Sarah Long's book, he's mentioned. He's not only mentioned, he wrote the chapters. And Jeff's a very approachable and a very, very nice guy. But he's the one who told us that if you use the lower dose at 15 milligrams, which is bacteriostatic, then the frequency of the retrobulbar neuritis is very, very low in kids. He didn't say it's zero. He can't say it's zero. But I have never seen the case. My understanding is that I believe this to be true. If you catch it early enough, and obviously this is going to depend on careful education of the patients. If you see it early enough and you stop it, I think it may be reversible. Okay? I do know that there have been cases where there's been serious vision loss as a result of it, though.
Just want to add a comment about that, about the treatment, tuberculosis treatment, okay? You identify a patient with tuberculosis and you need to contact the TB program because these are not drugs that are delivered over the counter, okay? Or you don't have, let's say, you know, there is no jurisdiction, or as a medical doctor, if you identify, you are not the one who is going to treat the patient. You need to send to the program, and the program needs to give you, you know, the feedback about the patient. Okay, that's for controlling and to not have resistant drugs, drug resistance in the country or in other parts of the world. I don't remember if in the States it's the same thing. But what I remember, you know, that we have control. The drugs are not over the counter, okay? So you cannot prescribe the drugs. You need to send the patient to the national program, and close to the house will be a unit that will identify, you know, the prescription, the diagnosis, and they will treat the patient as DOT, using the DOT strategy, okay? The DOT is direct observation therapy. Okay, so we need to see that the patient is taking the drugs, right? Okay.
I would agree totally with Eddie on that. And the reason is that what's been happening in Africa is that because many of the patients have been less than compliant, it has fostered the development, you know, single drug resistance, one thing. Multiple drug resistance is another. extreme drug resistance, which is defined as in addition to usual resistance against INH or rifampin, but also resistance against at least 2 of the second-line agents. And I showed them up there. I didn't talk about them. But then you're in serious problems. And many of those patients are co-infected with HIV, and most of those patients are in Africa. But in this age of jet travel, as I mentioned during the talk, somebody gets on the plane and they're not well screened. They may infect a number of people around them.
So you spoke about the the PPD. What exactly, in relation to what Dr. Perez said, what exactly is the sensitivity or the specificity? And is there anything that is going to replace it as the standard for testing the general population?
Yeah, it's difficult to give you uniform figures on that because there's a number of different reports on the sensitivity and specificity in different populations, okay? There's a lot of factors that go into it, how it's placed, how it's interpreted. If we're looking at PPDs that are being done out in the field, in the bush in sub-Saharan Africa, whether the cold chain's been maintained or is the material, has it gone bad? There's a lot of factors that go into it. It's difficult for me to give you a intelligent answer. And this is and the other thing is BCG will give you a false positive reaction. But the dictum is usually that reactivity will wane within 2 to 3 years after you get the BCG. Now, most places in the world will give BCG to neonates, and it does not prevent pulmonary TB, but it does appear to be beneficial in decreasing the frequency of extrapulmonary or disseminated TB. So the frequency of miliary TB, TB meningitis has been decreased with the use of BCG. Some countries, many countries, will give a second dose or recommend a second dose, usually I think at 7 or 8 years of age, something like that. You talk to a number of the residents in our house staff. I'm not just talking to pediatric residents, I'm talking across the board. I mean, Jackson is an 1,100-bed hospital, so we have multiple different residency programs. A lot of them who have come from various countries in South America will say, well, I've had BCG and I'll be positive. My response to that is if you had BCG years ago and you have more than 10 millimeters at this point, you may have BCG prior, but that's not giving you 10 or more millimeters. That's consistent with interval exposure to TB and having latent TB.
And also remember the class that we have, about sensitivity and specificity on PPV and MPV. It depends on the scenario. So for diagnosis purpose in this country, probably the sensitivity and specificity is not that high for diagnosis. But if you have a person here with a PPD, a positive PPD, definitely he was exposed to a mycobacteria, not necessarily tuberculosis, but a mycobacteria. But if you had prevalence disease here, if the prevalence of tuberculosis is very high, you suppose, that the PPD is positive because of the MTB. Okay, but any mycobacteria, correct me if I'm wrong, any mycobacteria could give you, a positive PPD.
Certain species can give you a degree of cross-reactivity, not all of them, okay? But what he's talking about is exactly correct in the sense the problem with PPD is the issue with specificity, okay? And this is exactly, and it's the problems with the PPD, and it's also the difficulty of diagnosing primary infection in a very young child that has led to a lot of the pressure to develop things such as the PCR. And the next thing, I quite frankly think that Ed's assay, because I've seen some of the preliminary data from a relatively small number of adults, and it's very good. And it makes sense. Rather than rely upon an immunological response, you're looking for something coming directly from the organism that's in the plasma.
And going back to your questions about research, I have a research, in terms of PPD, positive PPD in the country. 6 out of 10 Dominicans are positive. 6 out of 10. So adults. Yeah. So when you have a positive PPD, that doesn't mean that has tuberculosis.
Have you all been screened for PPD? How many are positive?
I just had everything.
Okay, but no one else had it.
I do a survey, about BCG also, with the second cohort. We love, these issues. What else? There is another comment, question? Vincent?
Okay, so mine is similar to what Bernardo was asking. But let's say, for example, you get the PPD and you need treatment. Where in this country, where does one person go to get that treatment? Since they have to be observed and everything, where would they go to get the treatment?
Let's say, that you identify a patient here and he lives in San Cristobal, okay? Close to his or her home should be, let's say, like a branch from the Ministry of Health, okay? It could be a hospital, could be a subcentro, could be a O&Med, okay? That will be responsible to give the treatment to the patient, okay? And to observe the treatment, okay? That's something that is responsible from the Ministry of Health and the program, specifically the National TB program, right? Did I answer your question? Okay.
DOT is usually reserved for people who have clinical disease. As far as I know, unless you're doing it here, DOT is not for people who just have latent disease and they're just taking INH. Yeah.
No, we don't use it for latent disease, okay? We use for treatment, okay? With the person who has tuberculosis, okay?
The other thing is, while you're on INH, you can't drink.
Yeah.
Sorry.
That's the principal cause of abandon here, is alcohol. Another study that Dr. Perez conducted here in the country, okay? Any questions, comments? Okay, so, again, let's give an applause. We have something upstairs, right? Like refreshments. Okay, so let's go.